All right, we're back, and let's talk about sexual responsiveness. I didn't really talk about that in emerging adulthood because, really, it's in emerging adulthood. I did talk about frequency of orgasm and stuff like that, so I guess I kind of talked about it. But in adulthood, with age, between the ages of 25 and 65, we're going to see that it takes longer, in particular for males, to become fully aroused. And that's a change, right? An 18-year-old male might just think something sexual and become fully aroused, or the wind might be blowing the correct angle. I mean, spontaneous erections happen all the time in younger men, but in older men, there may be more, activity that has to occur, and that's actually kind of a benefit. If the older male, who's 50 or above, is with an older woman who's, or even just a woman, if he's with a woman, his slower arousal is going to actually start to match the naturally slower arousal of women. And so that's actually kind of a benefit in the long run. It takes longer for the male to reach orgasm with age. So noticeably, measurably, it might be slower over age 50. And again, that might be something that is to the benefit of a heterosexual relationship, because on average, because women take longer to become fully aroused, having a man who's taking longer to become fully aroused and then ultimately to reach orgasm might mean that their sexual cycle is matching better during the activity. Now, in males especially, but for sure for females also, greater satisfaction is reported when they're in monogamous relationships. So notice I said especially for males, because look how much more satisfied males are in monogamy, especially as they age, right? So the 25 to 29-year-olds, the men are less satisfied in monogamy than the women. By 30 to 34, they're equal. By 35 to 39, the men are a little bit more satisfied. For some reason, 40 to 44, they go back to equal. But then 45 to 49, 50 to 54, men are much more satisfied when in monogamy, even than women are. And then by the time they're at 55 to 59, they're back to matching. And so what we're seeing is that, going back to the myth of once I get married, I'll never have sex kind of idea, monogamy doesn't necessarily mean marriage, but being in a committed relationship seems to be beneficial for both male and female satisfaction and comfort. Whereas we sort of have this myth that only women want monogamy. Maybe younger men like more variety, but as men get older, they start to really appreciate monogamy. Let's talk a little bit about fertility and some things that are worth discussing with regard to fertility. I talked before in 18 to 25-year-old age bracket that that's a really healthy time to be having babies, but it's not the common time in the US, right? In most Western cultures, that's not the common time to be having babies. So a lot of us are deferring childbearing until our 30s and maybe even hoping that we can do it in our 40s. So I wanted to talk a little bit about how our fertility and the health of the offspring can be affected by maternal and paternal health, our age, I meant. So you'll notice here on this graph that the rate of trisomy 21, which is Down syndrome, how the rate is really super low through up until about 30. It starts to come a little bit off the floor. Trisomy 21 starts to come up off the floor here. It's the blue squares right around age 33. It starts to come up off the floor a little bit, just a little bit. And then it just is this nice sort of logarithmic, more and more likely to occur with age. So by the time you are at age 49, it's 1 in 11, whereas at age 20, it had been 1 in 1,667. So all the way up until probably about age 33, the rate of trisomy 21 is really, really super low. But then with every year after age 35, the risk is like doubling. So delaying childbirth for women past the age of 35, it really significantly increases the risk for this particular outcome. Most women tend to have babies between the ages of 25 and 40. And so if that's the case, pushing it closer to, 35 and under makes, sort of healthily better sense than pushing it closer to 40. But I mean, if we were able to calculate out the risk here at 40, it's still very low, less than 2% chance. So, but it's a bigger risk. With increased risk, we have increased birth defects. Now, I've shown you this picture before in another lecture, but I'm going to do it again here where, again, I wanted to emphasize that maternal age and paternal age play a role in the development of autism spectrum disorder. So as the mom gets above, again, 35, for the man, if he's starting to get above about age 40, we start to see higher rates of autism spectrum disorder in their offspring. Here we have schizophrenia. And this is paternal age that seems to be the important factor for the development of schizophrenia. So if we have the y-axis is displaying the incidence of schizophrenia in 1,000 people. Just FYI, schizophrenia affects about 1% of the population, 1.5% of the population. So when we are looking at these numbers out of 1,000, they might look really large, but remember, it's out of 1,000, not out of 100. So if the dad is age 20, you're going to have 1 out of almost 200 cases where schizophrenia would occur. So it's very low. Six out of 1,000 might develop schizophrenia. By the time the dad is 50 years old, your schizophrenia risk is like 16 out of 1,000. It's still really small, but it's a risk that goes up with age. I'm stammering just a teeny tiny bit because I'm just really trying hard not to say a really obvious comparison, which is I'm recording this in January of 2022 and COVID's still going on. So when you say that you've got a 1 in 16, if you've got 16 out of 1,000 people developing schizophrenia, that sounds like a really small number. But now transfer that over onto to COVID and the number of people in your age bracket who use the same model, but use your age bracket and their likelihood of dying of COVID. And a lot of people will say, well, if 1 in 1,000 dies of COVID in my age bracket, that's a lot. That's scary. That's a lot. Like, we've been really scared about that. But then when I say 16 out of 1,000 on schizophrenia, people go, oh, well, that's not that much. I think it's somehow COVID was very much on our minds and really projected as it was going to get all of us and kill all of us in a way that we can dismiss other risks sometimes when those numbers are the same. Schizophrenia going from 6 out of 1,000 to 16 out of 1,000, that's a big change. So something to consider. I just thought I'd just blow you away with this long list of genetic conditions that are associated with advanced paternal age. So these are all things that have been tied to dad being older. And, some of these you may recognize and some of them you may not. But I wanted to insert this because a lot of times we kind of forget that dad's age might matter. We know that mom's age might matter. And we oftentimes think that the one thing that'll have an impact on is the likelihood of Down syndrome. And we really don't ever think about what dad's age might do. We say, dads can have children into their 80s. Well, they can, but they may be, their sperm may carry genetic errors in them that can cause these different disorders. Mother's age at delivery, ranging from 20 to 45 on this chart, and then the risk of having a child with any kind of chromosomal disorder at all. So if you're 20 years old at delivery time, your risk is 1 in 526. If you're 45, your risk is 1 in 21. Now, 1 in 21 is still roughly a 5% chance that something might happen, but that's a really significant increase in the likelihood of something happening with advanced age. So when I'm saying that people tend to be healthier and the babies tend to be healthier and stuff if mom is 35 or less, I'm not trying to say that to force everybody to have babies when they're not ready, if they're going to have kids. I'm saying it because statistically, you're better likely to have, chromosomes that are organized as they should be the younger the parents are, and that's just what it is. I'm stammering because sometimes people think I'm saying something mean, and I'm not trying to say anything mean. 15% of American couples experience reduced fertility, and it's most common among those people who delay parenthood. Like, if parenthood is on the horizon for a person's future plans, the longer we delay parenthood, the more likely we are to have infertility, or reduced fertility. If we look at the typical causes of fertility problems, about 40% of the time it's going to be something having to do with the father's reproductive system. About 10% of the time, the doctors literally can't figure out what the problem is. And then the remaining 50% of the time, it's something going on with the mom's reproductive system. So 10% of the time she has blocked fallopian tubes. 20% of the time she's not ovulating when she should. 20% of the time she has a condition called endometriosis, where there's a disruption of the endometrial lining of the uterus. The good news is that the ovulation problems typically can be treated very easily with some medications that trigger ovulation. Blocked fallopian tubes can be tricky. A lot of times you can just go ahead and go around them by doing a variation on in vitro fertilization. With the male reproductive system, a lot of times it's sperm mobility issues or low sperm count, something like that. And those things sometimes can be cured with something as simple as a change of, underwear style, or not wearing too tight of pants and things, because the testicles need to be cooler. But other times it can be really perplexing and really difficult to treat. So I like this chart because it illustrates very graphically that it's almost as likely to be on the male side of the issue as it is to be the female. Typically, when there's infertility problems, couples will look first to the female. Like, you go get all your stuff checked out before I get my stuff checked out. When in fact the checkout for the male is to ejaculate in a cup, and we'll check the sperm, whereas for a female it's let us put endoscopic cameras up through your cervix and into your fallopian tubes, and let's draw blood and a bunch of more invasive things. And for a lot of couples, they'll go to the female tests first before checking the male to see if it might just be sperm issues. And that really gets at some issues that have to do with virility and masculinity and things like that. And a lot of times people will say, well, it's the woman, she wants it more. She wants the kids more. I think it's more insidious than that. I think it's more that there's sort of this assumption that there can't be anything wrong with men making sperm. I mean, after all, they can make babies into their 80s. All these sort of stereotypes and myths that we say. And we don't consider the possibility. And in fact, it can be kind of emasculating for men to find out that they have a fertility issue. I would just like to throw out there that it can be kind of defeminizing for women to find out they've got a fertility issue. It's neither partner tends to feel very good when they find out that there might be something that's causing them not to be able to become parents when they want to. So it's just kind of interesting that we will do all the invasive stuff checking out the female first, and then if only everything comes out clear for her, then we'll come back and check what might be going on for the male. Well, let's go ahead and stop real quick because I want to go through menopause and andropause together. So let's do that in the next segment.